talking about an acute kidney injury now. Acute kidney injury, of course, is acute, right? So there's an incident that happens that damages the kidney, and they sustain a kidney injury. So usually the offending, whatever it is that causes the injury, happens about 48 hours before the kidney sustains an injury. And there is rapid loss of kidney function. And so you'll see like the creatinine go up drastically in a couple of days. And there's, if you look in your textbook, there's like, in this stage it goes up 0.5. You don't need to know that. You need to know that it's rapid loss of kidney function. So an acute kidney injury affects many body systems, and chronic kidney disease affects all body systems. So when you think of acute kidney injury, there's a couple phases that I'm going to take you through. But what I want to point out is the oliguric phase of acute kidney injury has the same signs and symptoms as chronic kidney disease. So you don't have to learn things in compartments, okay? You can just learn it together and it will be better for you. And if you could take some time and just spend some time on some of the recordings I provided, like renal, A&P, or the wet bed, it will give you a general idea about what's going to happen if the kidney is not functioning the way it should. Okay, so that's like a generalization. And if you can learn that, that'll make this so much easier for you. The GFR is always going to be the best measurement of kidney function. So the glomerular filtration rate, it mirrors the creatinine clearance. But to get the creatinine clearance or the GFR, you have to do a 24-hour urine. So that's why it's not done as much, and that's why you use the creatinine as your kidney function test, okay? The normal GFR, yes, does decline with age. It's going to go down when the kidney is damaged. With an acute kidney injury, hopefully it'll go back up as the kidney is healing. Now, there's 3 general ways that a patient can sustain a AKA. There's pre-renal causes of acute kidney injury, and this is due to decreased perfusion. So the kidneys are underperfused for some reason. It could be due to the 3 Ds, diarrhea, dehydration, diuretics. It could be because somebody had a myocardial infarction and now the heart is not pumping efficiently, so the kidneys are underperfused. Hypotension, so a MAP less than 65 for an hour, so people in shock could sustain a pre-renal AKI. People in heart failure can, they have a high BNP, that's how you tell. Liver failure. So with liver failure, recall you have a low albumin. The patient has ascites. In other words, their fluid is third spacing, so that there's not a lot of volume in the vascular system, so the kidney is underperfused and they get that hepatorenal syndrome. Burns, we're going to learn about that at the end of this semester, but in the emergent phase, they lose a lot of fluids. Shock of all types. Renal artery stenosis, and thrombus. So something that clogs the blood flow to the kidney before it reaches the kidney. Okay, and then when we go to intrarenal causes of AKI, this is causes that damage the kidney. So think about your nephrotoxic medications, okay? So your aspirin, your loop diuretics, your platinum-containing medications like cisplatin, your aminoglycosides, your aspirin, your NSAIDs. And furosemide, I said, ethacrenic acid. Ethacrenic acid is a loop diuretic, and it's often given to people maybe who have a sulfur allergy. Sometimes with furosemide, if somebody has a sulfur allergy, they'll react to furosemide as well. Zoledronic acid is a biphosphonate, so like people with osteoporosis may be at risk if they're taking this medication. People with lupus or scleroderma, that damages the inside of the kidney. Hypercalcemia, and that can damage the kidney. And normal saline is administered at high rates if they're not oliguric to kind of flush the calcium out. Contrast medium, we talked about that. Hold the metformin, you know that. And contrast medium again to prevent contrast-induced nephrotoxicity. Check the BUN and creatinine before. The provider may order normal saline. Normal saline is the flushing fluid. Bicarb or acetylcysteine before the procedure. Diuretics and fluids may be prescribed after to flush out the kidneys. Diabetes, people with diabetes are at risk for intrarenal, especially if they have tests with contrast dye, like a cardiac cath, CAT scan, MRI. Okay, I usually don't tell students to do Quizlet. I tell you to do whatever works for you. But I would suggest doing the Quizlet that has medications for exam 3 and also the one about calcium, hypercalcium or hypocalcium. For some reason, students get turned around on the exams about the signs and symptoms of a hyper or hypocalcemia. All right, now we're going to talk about post-renal causes of AKI. And this is due to an obstruction in the urinary system. So like bladder cancer, colon cancer, which is very close to the bladder as well, can press on it. BPH can cause urinary obstruction. Kidney stones, neurogenic bladder, so like people with spinal cord injury can suffer a post-renal UTI. All right, people with structural deformities in their ureters, they can also get a post-renal ATI. Health promotion and maintenance. Question, this is for anybody in general at risk for kidney disease. Question all nephrotoxic drugs. Evaluate patient's fluid status by using daily weights. And I think you already know 1 kilogram equals 1 liter of fluid. You want to do INOs on all your patients. Drink 2 liters of water a day if it's not contraindicated. If somebody report a UO less than 0.5 milliliters per kilogram per hour times 2 hours. You're going to monitor the labs that reflect kidney function, so the GFR, the creatinine, and the BUN. Pre-medicate before contrast dye with IV fluid, normal saline. It's a flushing fluid. 1 liter of 0.9 normal saline with an AMPA bicarb or acetylcysteine. All right, check the urinary output after the procedure. Make sure you're doing your peaks and troughs on your aminoglycosides. And older adults especially are at high risk. And I think, I don't know if I talked about it in this lecture or another lecture, but 10% of the people who sustain an acute kidney injury never heal, and they end up getting AKI, chronic kidney disease. And it's usually our older adults, and it's not fair. That's why I'm telling you about all the different risk factors that can cause an acute kidney injury. So when you are working, you'll be able to identify these type of patients and keep an eye on their urine output. Phases of AKI. So there's 4 essential phases. So the onset, and this is what I was talking about earlier. So they have whatever caused it, a pre-renal thing, like their blood pressure was low for 2 hours. So 48 hours after that, you may see they may become oliguric and their creatinine is going to go up. So the oliguric phase lasts 1 to 3 weeks. The diuresis phase lasts 2 to 6 weeks. And when they start diuresing, that's when you know the kidney is healing. Recovery can take up to 1 year. So check your patient's history. You're going to look for the signs and symptoms. Oliguria is less than 400 milliliters per day. The urinalysis is going to be fixed at 1010. I don't know if I talked about this in another lecture. I think I did, in the kidney disorders. So this is indicates kidney disease when the kidneys can no longer concentrate the urine. They're going to have metabolic acidosis with Kussmaul's respirations, hyperkalemia, and hyponatremia, elevated BUN and creatinine, fatigue, and malaise. Then, when they go through the diuretic phase, they're going to have an increase in urine output. This says 1 to 3 liters a day. It could be up to 10 liters a day. So you're going to watch for hypovolemia. You got to stay ahead of it while they're diuresing. So monitor the potassium too. You're going to worry about a low potassium. So look for like PVCs on the EKG, U waves. BUN and creatinine is going to start to normalize and your GFR should go back up. And then the recovery phase begins when the GFR is increased again and the BUN and creatinine go back down. Whoops. Okay. All right, now the oliguric phase. The urinary output, you'll notice at first, is going to be less than 0.5 kilograms per hour for 2 hours. You are going to see sediment in the urine if it's due to an intrarenal AKI. You're going to be most concerned with fluid overload, so cardiac and pulmonary status. Listen for the S3 heart sound. Listen for your crackles. Low O2 sat is another indication that your patient is maybe fluid overload. And a soccer. Remember, they're going to be put on that fluid restriction. You take the output for 24 hours and you had 500 or 600 mLs. Your expected lab changes in AKI is the same thing I was talking about in a wet bed, okay? So the creatinine is going to increase. The BUN is going to increase. The potassium will increase. The phosphate will increase. Magnesium will increase. And then your GFR, your calcium, your hemoglobin, and your pH are going to decrease, maybe. Maybe in AKI, but definitely in chronic kidney disease. Yeah, so they're going to need a diet at this stage when they're in the oliguric stage, all right? They're going to need a diet, low protein, high carbs, low sodium. And remember the EKG changes, the peak T waves, the widened QRS, the prolonged PR interval, which we call first degree block, okay? And then bradycardia and asystole. So they could die from the high potassium. The diuretic phase, the urinary output signals that the kidneys are healing, so they can put out a lot of urine. So monitor for hypokalemia. So the opposite of what you were going to monitor before. So if you see somebody with a first degree block, make sure or you see somebody with these signs and symptoms or the signs and symptoms of hyperkalemia, okay, make sure you get an EKG. The specific gravity, the now is going to go back up and the symptoms of dehydration will get better. Okay. Decrease in BUN and creatinine. GFR should increase. And then weight loss and low CVP. Okay. So the patient's going to need fluids to be replaced. Okay, AKI drug therapy. Okay, so early on, most of the reasons people have an acute kidney injury is due to perfusion problems, like 90%. Okay, so I think you might get those kind of questions on NCLEX, but I also think you're going to get questions about nephrotoxic medications. So what they might do is if somebody had an underperfused kidney, they might give a fluid bolus and chase it with some furosemide to see if that'll push like the fluid through, so to speak. All right. Patients with AKI may not need dialysis, but some may need dialysis. Protein requirements. So if somebody is oliguric, it's 0.6 grams per kilogram per day. And you don't need to memorize that, okay? Remember, like the normal person needs 1 gram per kilogram per day. So I'm just pointing out that they're going to need a low protein diet. Now, when patients do get hemodialysis, okay, they are going to need more protein, so like more like a normal person, 1 to 1.5 kilograms per day. Before they get hemodialysis, they're going to be on the low protein diet. Peritoneal dialysis has even more protein loss involved with it, so they need to eat even more protein. Okay, so you don't need to know like the numbers, you just need to know AKI, oliguric, somebody with a low GFR, somebody with chronic kidney disease, stage 3 and up, needs a low protein diet to prevent them from getting encephalopathy. All right, indications for kidney replacement therapy is AEIOU. So somebody that has acidemia, somebody that has a high potassium, somebody that is intoxicated and has kidney disease because they can't get rid of it, fluid overload, uremia, pericarditis, neuropathy. What labs would be improved by kidney replacement therapy? That's the word for that's the term for hemodialysis or dialysis now. You would expect your potassium to go down, the pH would be normal, the BUN would decrease, creatinine would decrease, and the patient would weigh less. The hemoglobin would not increase; it would decrease. So everything basically is improved, but the hemoglobin by dialysis. Hemodialysis works by diffusion. It's not really an important distinction. And continuous kidney replacement works by hemofiltration. Now, why somebody would have to get continuous kidney replacement is because their blood pressure cannot withstand hemodialysis. Hemodialysis is like a 3 hour or 4 hour long session, and it's going to drop their blood pressure. So critical patients that are critically ill get continuous kidney replacement, and they're going to be in the ICU. Okay, vascular port used for dialysis. This is like a permacath. What else do they call it? Quinton cath. I can't remember all the names for the different ones. But anyways, this is only used for dialysis. You don't use it to infuse your IV fluids. You don't use it to draw blood. You don't manipulate it. Only the dialysis nurse uses this. Continuous kidney replacement therapies are for unstable patients. And it's only used in the ICU for unstable patients. Continuous venous, so vein to vein hemofiltration, which is most commonly used, you use a pump with that, okay, because it's venous to venous, okay, and usually that's through like a central line. So they're going to be at risk for air embolism because of that, because they use like a pump. Okay, so that's the beginning of acute kidney injury.